Thanks for the opportunity to speak here today. Just changing pace slightly now to talk about fungal infections. So my disclosures. So in summary, I'm going to talk about current invasive fungal infection risk groups by way of background. Then I'll talk about the rationale for aggressive and early therapy and talk about the treatment options and the evidence for treatment. So I guess we're all pretty familiar with the risk groups for invasive fungal infection, as you can see on this well-known sort of summary here, that patients with prolonged neutropenia, graft versus host disease, high-dose RSC, corticosteroids, or a combination of corticosteroids and neutropenia. And of course, when Prentice originally developed this risk grouping, he did list fludarabine. As we now know, it's not a particular risk factor for fungal infections when used alone, but it was probably the start of agents that affect our T-cell function. And I guess we've developed on those over the years, and so we now have agents such as Campath, which do in fact impart a risk for fungal infection. Of course, the seminal work was done by Gerson, and his very elegant paper linking the duration of neutropenia for the risk for fungal infection still holds true today. Well, there's been some developments in the area of prophylaxis. An important study by Cornely did show that prophylaxis for AML and MDS patients who were receiving intensive chemotherapy with posaconazole did in fact reduce invasive fungal infections and also improve survival. So thereafter, the rationale for anti-mold agent prophylaxis was really proven. Before that, we'd been used to using the earlier azoles such as fluconazole, particularly in the transplant setting, but this was really the first study that showed a definitive benefit from anti-mold prophylaxis. And I guess I'll just going to show a little bit of data from our own hospital, the Royal Melbourne. And over the years, as you can see on this table, we've used a number of different prophylaxis for our acute myeloid leukemia patients, starting off with fluconazole and graduating through voriconazole, posaconazole, and for those who couldn't tolerate oral posaconazole, IV ambisome. But I guess the important thing in this summary slide is that we found a similar result with posaconazole in our real-life patients outside of clinical trial, that we did see a reduction in invasive fungal infections and a reduction in mortality. Interestingly, we also saw that with voriconazole, which we'd used in an earlier time period, but we switched from voriconazole to posaconazole when the Cornely paper came out, indicating that there was some evidence. Of late, of course, there are some papers coming out regarding voriconazole prophylaxis in stem cell transplantation, and Winston has recently published his large prophylaxis study, and there's also a study coming from Europe led by David Marks. So again, some more data coming out on mould active prophylaxis, and we look forward to those publications. Well, what about patients where we still see invasive fungal infections? Of course, it's not all rosy. Even though we do have the new mould prophylaxis agents, we still see issues, particularly in some autologous transplant patients who may have had heavy pretreatment. We also see relapsed AML patients and MDS patients presenting with fungal infections before they've actually started on any treatment. We also see it in ALL patients where we can't use anti-mold active prophylaxis because of interactions with vincristine. And of course, some CLL and myeloma patients who've had extensive treatment. So although we have some evidence in the area of AML and stem cell transplant, we still don't quite know what to do with these other groups of patients in terms of preventing infections. One of the other problems, of course, is that we are limited in our diagnostics. We all like to have a biopsy and histology to prove a fungal infection, but we very rarely get it. And what we do have, the tests such as bronchoscopy, do lack sensitivity and specificity. And although we have new non-culture-based tests, such as the galactomannan test and also PCR and BD-glucan, these non-culture-based markers for invasive fungal infection, they're still really finding their role and haven't really made it into widespread clinical practice. So unfortunately, we're still in the situation as we were back 10 years ago, where very few patients actually have a proven fungal infection. So we're left with the situation that we wish to treat these patients early, but we are not very good at making the diagnosis. Again, the importance of early therapy is not something that's new to us. We knew about this from some work done in the 90s, looking at the mortality of patients who develop pulmonary infiltrates during AML chemotherapy, and showing that delay in treating those pulmonary infiltrates led to a worse outcome. And I just show a picture here of a patient who started off with a couple of nodules in their lung on CT scan and was not delayed in treatment, but actually got the incorrect treatment. This was a zygomycosis case, and the patient was treated with a drug that wasn't active, and within 10 days you can see the progression of this lesion on the left-hand side. Well, there is some good news about invasive fungal infections. We have managed to, over the years, improve on survival rates, such that on this graph of data from the Fred Hutch done by Arlo Upton, we can see the improved survival here in the latter years of this study of patients who were diagnosed with fungal infections as compared to the poorer survival in the earlier time periods. Now, this probably correlates with a number of different things. Newer antifungal drugs were becoming available in this time period. Also, the concept of early treatment was becoming better understood. So there may be a number of factors influencing this. What has been traditionally thought in terms of early treatment to look for the halo sign on CT scan, but of course the halo sign is not specific to Aspergillus. It may also occur with other mould infections and even with bacterial infections. So although we have one marker here, it's not a perfect marker, and it only occurs in the neutropenic patient. Well, what is the rationale for early treatment? Some of the large studies that have been done recently, for example, the voriconazole versus amphotericin B study, clearly showed that patients who were treated with a proven diagnosis, whether they got voriconazole or ambazone, did less well than those who were treated at the time of a probable diagnosis, that is, less progressive disease, less advanced disease and infection. That was also the finding from another large study, a comparison of 2 doses of ambazone, the AMBERLOAD trial. And again, there was a definite difference in survival for those patients who were treated at an earlier stage of their infection. Well, so we've tended to rely on the halo sign because it's one of our few diagnostic markers. But unfortunately, it may not be that simple. And there's been a recent review by Alia Nacy's group looking at patients with myeloma and saying that, okay, these patients actually didn't have halo signs. They had a positive galactomannan marker in their serum for Aspergillus, and they had things like consolidation, ground glass, pleural effusions, not the things we would classically think of as signs of invasive fungal infection. But these patients actually had the same outcome and required the same treatment as those who had, in fact, a proven or probable invasive aspergillosis. So although we rely on the halo sign, this group has now showed us that perhaps we are putting too much emphasis on this. And of course, a number of these patients weren't ever neutropenic and so never had the opportunity to develop the halo sign. Well, what drug do we select? We've mentioned we want to treat patients early. We want to get in there early. We want to not wait until they have advanced disease. And I guess the agents that have been trialled, I've just summarised some information about here. The initial trial that we had compared voriconazole to amphotericin B, and of course showed a better response rate and 12-week survival with voriconazole. These results were pretty similar in the amyloid study, which compared 2 doses of amphotericin B, a high lipid amphotericin B dose versus an intermediate dose of 10 versus 3. And again, similar response rates, similar 12-week survival. What about the echinocandins? And here's where we have a little less data. For caspofungin, there have been 2 smaller single-arm studies, not randomised, but treating patients with either haematologic malignancy, generally AML, with not such a good complete and partial response rate, but a similar overall survival. And again, similarly in allogeneic stem cell transplant, a complete and partial response rate of 42. So slightly diminished from what we saw with the voriconazole or the liposomal amphotericin B, but perhaps explained by the nature of the patients in these studies. For example, the AML patients were not in remission. Many of them had prolonged neutropenia and didn't recover their neutrophil counts while on treatment. And that we know is a poor prognostic indicator. So these studies may not be directly in comparison to the earlier studies of voriconazole and liposomal amphotericin B. So all of this background data has gone to inform the IDSA guideline recommendations, the Infectious Disease Society of America, who've come out and recommended voriconazole as their first-line treatment, and lipid amphotericin B as an alternative agent, both with an A1 recommendation as compared to the echinocandins, which have a lower grading recommendation because of the paucity of data. So I guess in conclusion, what we've discussed is that prophylaxis is a useful strategy for high-risk haematologic malignancy patients, but risk groups for invasive fungal infection are expanding, and not all risk patients are currently well recognised and characterised, and therefore not all of them are getting prophylaxis. Invasive fungal infections still occur in these groups. Early treatment of fungal infection improves outcomes, but our diagnostic capabilities do need improvement. So the challenge for us in the next few years going forward is to target early treatment appropriately to those with early invasive fungal infection. And I think we haven't seen the end of the studies. There's currently a combination therapy, first-line combination therapy, study going on with voriconazole and inidulafungin compared to voriconazole alone. So I think in the area of fungal infections, we will still see some data emerging. And of course, there is a lot of work being done on how best to use the non-culture-based techniques for diagnosis as well. So in the next few years, I think this area will continue to change. Thank you.